Hi, everyone. Thanks for sticking around. We have another excellent speaker for you. My name is Pat Patrician, and I'm a professor at the University of Alabama at Birmingham. And it's my honor and pleasure to introduce one of my nursing heroes, Dr. Doris Grinspun. She is the Chief Executive Officer of the Registered Nurses Association of Ontario, RNAO, in the province of Ontario, which is Canada's largest jurisdiction. She's the founder and visionary of RNAO's internationally renowned Best Practice Guidelines program. And this program is amazing. If you're interested in some evidence-based practice guidelines, they're available for you on the rnao.org website. There's a lot of great tools there. She's a leading figure in Canadian and international health and nursing policy. Dr. Grinspun, before she went to RNAO in '96, she was a director of nursing at Mount Sinai Hospital in Toronto. She was born in Chile, as you can tell by her accent when she comes on, but she was educated in Jerusalem for her nursing education, and she received her MSN from the University of Michigan and PhD in sociology from York University in Toronto. She is an adjunct professor at the University of Toronto and the University of Ottawa Schools of Nursing. She has received so many awards from the Government of Ontario, various international nursing organizations. She's a fellow of the American Academy of Nursing and of the Canadian Academy of Nursing. And in 2020, she was honored by the American Academy of Nursing with the COVID-19 Courage Award in Policy, which honored her incredible contributions to save lives, advance health equity, and protect communities during the pandemic. She was recently published Leading Change, which is an incredible tool to help you implement change and improve care. This is available on the RNAO website. I've known Doris for the last 7 years, and she is a force to be recognized. She will be talking to us about starting a movement. Doris.
Thank you so very much for having me with you today. For this closing keynote. I congratulate all of those that have decided to stay and hear it. And let me start by congratulating the International Forum for this event and Patricia Patrician for inviting me, as well as the organizers. I will be sharing, first of all, a Twitter challenge. Why? Because you can receive this book, whether in English or in Spanish, of your choice, of Nursing Through Knowledge, which is, by the way, the first book that Sigma translated to another language. So another kudos for Sigma goes. All you need to do is, during this presentation, until the end of today, do a tweet. And the Twitter needs to have the hashtag BPG or the hashtag BPSO, and then tag along RNAO and tag along myself, and we will give you links. And you will see during the presentation why this Twitter challenge is important and how RNAO uses social media to create a actually social movement. So first, let me start by a land acknowledgement, which to us in Canada is tremendously important, and RNAO does it at every event. RNAO is located on Huron-Wendat, Anishinaabe, and the Mississaugas of the Credit, and that is Treaty 13. And in fact, I live also in Treaty 13. This with one spoon, Wampu, Belt Covenant, agreement within the Iroquois Confederacy and the Ojibwe and Allied Nations. This land is the home to many First Nations, Inuit and Métis peoples from all across Turtle Island. Land acknowledgement are an act of reconciliation, and we must all do our part. And I am not so sure that in the US, it's very common to do land acknowledgements ahead of a presentation. But here we believe it's a critical action to take as an act of reconciliation. And you probably have heard a lot of the hardships that that indigenous people have gone through in the last thousands of years, but specifically with the discovery of children in indigenous reserves and the such. So we have a report that is called Truth and Reconciliation. It has 94 recommendations, and RNO as an association is very, very engaged in helping nurses understand that without truth, there is no reconciliation, and hence why this land acknowledgement is so very important to us. I was asked to speak about starting a robust quality improvement movement, and our colleagues asked that we use RNO BPG, best practice guidelines, and BPSO journey as a case example. So that's exactly what I plan to do with you for the next 30 minutes and then leave for some questions. I want to start by sharing the place of evidence during the pandemic and how evidence can also be a solution. Very briefly on that. Then I want to speak with you about the elements and the tools for success of a robust quality improvement movement. And of course, I could not end this presentation without dedicating the bulk of it to RNO's well-renowned best practice guidelines program and the best practice guidelines spotlight organization as a lived example of quality improvement and as a lived example of how you build a robust movement. By the way, in this book, the first chapter is dedicated to how, even from the day I conceptualized this program to today, that is a humongous program with 50 people working full-time at RNO, many, many nurses, master, PhD prepared, support staff, communicators, and others. But more importantly, in addition to all of us, people around this world using this program to improve the health outcomes of people and how social movement is critical to it. So I was very inspired myself when I was asked to present about social movement, about quality improvement as social movement. Let me bring you greetings from RNO, simply so you do not leave this presentation mistaken, thinking that the only role of RNO is to develop evidence-based guidelines and implementation and evaluation of that program, which is a signature program of RNO. RNO is the professional association for registered nurses, nurse practitioners, and nursing students in Ontario. We have, when I joined RNO, just so you know what social movement can do to a voluntary organization, because we are voluntary, when I joined, we had about 11,000 members. We are close to 50,000 now. This is the result of social movement. This is the result of building a professional association that is strong, credible, leading the nursing profession to influence and promote healthy public policy and clinical excellence. And healthy public policy is one of the big pillars. The other pillar is the best practice guidelines program, and I will share from time to time how they intertwine. Just yesterday, we had provincial elections. So I was saying to our colleagues, to Mary, that actually I already had interviews about the results of the elections, right? And we were talking about how we need to bring the profession out of what I would think internationally, nationally here in Canada and provincially, is in actually deep crisis. I believe the nursing profession we have undergone an intense period during the pandemic, a period where we had many challenges and the profession offered many courageous and evidence-based solutions, We had the period where with fake news and the expansion of fake news through social media was relentless, right? From the vaccine changes the DNA to masks don't allow you to breathe well and you will have lack of oxygen to you name it, right? You name it. And of course, we came with evidence-based RNO from a policy perspective, pushing for healthy public policy. The issue of masks, we were the first ones actually advocating for the use of masks. Even lockdowns at the periods of the waves when they're very, very, very strong and we didn't have vaccine, that was a critical success factor for why in Ontario and in Canada overall, we have relatively less tragedy than in the US, although I must say we have a humongous tragedy in long-term care, and RNO has been very vocal and involved on that, including today in the news. Let me talk for a minute about the elements of a robust quality improvement movement, large-scale quality improvement movement, which in a sense, the best practice guidelines program, the spread and the success of it is a very solid example of large-scale quality improvement movement. Number one, location. You know, if this same program would have been only in a university, or it would have been in a place that doesn't have the resources that RNO has, communications department, the evidence-based guidelines department, the support of government in funding the program to this day, the capacity of IT, the capacity of responding like this to the needs in the sector, whatever sector that was and whatever country that was. Second, access. This program is free of charge. And I would suggest to you that any robust quality improvement movement needs to be free of charge, because otherwise you are only creating quality improvement for a small segment that can afford the cost of it. But when you do quality improvement for entire organizations, and as you will see with this program, entire countries, and we don't charge for it, and I am inviting you to join too. So any of you, we will put in the chat my direct email, and you can also put, Raul, please, the phone number so that people can WhatsApp me or you can DM me in Twitter. Is free of charge, from using the guidelines to implementing and sharing with you the PowerPoints, implementation tools, to the evaluation, of which Dr. Patricia Patrician is a member of the International Advisory Council, all of that free of charge. That is a key element of success. Comprehensiveness. You heard that I mentioned, and I will be reviewing with you, the three buckets of our program. It's not only we produce the evidence, right? So if you equate it to quality improvement, the quality improvement you want to do it, so to speak. We also provide an equally robust, comprehensive implementation program. And as I said, evaluation. So comprehensiveness, meaning providing the entire package of the quality improvement movement you want to do, is critical to large-scale success. Robustness, right? Some programs have very strong emphasis on evidence, and that piece is very strong and it's very peer review, et cetera, but then the implementation is kind of, shaky. It's not as robust, or the evaluation is not as robust. In our case, the robustness is across the three pillars of the program and the intersectionality between the pillars. Leading edge. You would think that a program that has a book translated in 2 languages and that is all over the world being implemented in more than 1,000 organizations, that, we will be sitting in our laurels and say, okay, let's keep going, only let's keep spreading. No, we are always looking at being at the leading edge, to the point that Patricia will be hearing some additional news next week when she comes to the advisory of what else we are launching to keep us at that leading edge, to keep us at both knowledge utilization, evidence utilization, in your case, quality improvement utilization, but also at knowledge creation. And then, of course, collective identity. You will notice that I go with this pin. And you will also see slides later on that this pin was not invented by RNO. This pin was invented actually by other organizations in other parts of the world, but it tells you about collective identity, that everybody around the world today that is involved in the program, they do have their pin. It might be attached different. They do have their logos for the Twitter, collective identity. You go to a conference, whether it's ICN or Sigma or any other, and you are in the hallway and someone sees the pin and says, oh, you are a BPSO. Oh, we are also BPSO. You don't even need to compare notes because people know what the BPSO means. And that is collective identity. And then proven results. A program of quality improvement, if it's robust, should not be a program that does not produce results. So proving the results is critical to a large-scale quality improvement program. So tools for success. Well, tools for success, first of all, we have all the social media of all kinds today. And that tells you something because at this day and age, when there is so much negative about social media and so much fake news and so much dividing and conquer and so much tensions, this program and any good quality improvement program brings energy to the nursing community and other health professionals and health systems around the world through actually social media. It brings energy, it brings evidence, it brings collectivity, it brings togetherness. That is very, very important. You will notice that we have...
This is Watford Quality Care Center here in Watford, Ontario.
There you go. There you go. Right? And that is thanks to Raul, who prepared that slide with the video so you can see the excitement in different parts of the country, in different parts of the world, in different parts of the province. That is collective identity. And I would add one more element, which I would call it energy, positive energy that comes out of that collective identity. Let me review with you the 3 pillars of the program, and those have not changed since the moment I clicked that proposal to government in 1997. That was an aspirational dream. I knew it would work, but never in my life did I imagine it will take over all over the world. And that is thanks to both the tremendous team of experts within RNO for each pillar, as well as the partners, the international and national and provincial partners around the world that have taken the program as is their own, because it is their own, because each country, each province, each jurisdiction needs to adapt the program without losing fidelity. Because again, if you're talking robust quality improvement, large scale, you need to make sure that it doesn't lose fidelity. That's actually a very important principle that we discuss in the book, and fidelity is critical. So the 3 pillars are guideline development, guideline implementation, and guideline evaluation. And I will not do justice in giving you everything about it, but I will touch a little bit just to open your appetite to this integrated evidence-based model for knowledge uptake, knowledge mobilization, knowledge sustainability, and yes, go forward, knowledge production of new knowledge with the use of artificial intelligence, which I will not get much to it today. What are best practice guidelines for RNO? Well, it's best practice guidelines are basically systematically developed statements and recommendations based on the best available evidence to inform decisions for better client outcomes and also for better work environments. We started the evidence-based guidelines. The first ones came out in 2001, and in 2003, the government also asked us to do evidence-based guidelines for work environment. So today we have those 2. We use the latest methodologies always, not only for the development of the guideline, but also for the grading of the recommendations. So we use grade for quantitative recommendations, grade circle for qualitative recommendations, and of course we use agreed tool, the agreed tool to meet all the requirements, the rigorous requirements of international guideline development. And yes, we are part of GIN, the Guideline International Development Organization. We organize the guidelines into buckets. We have 49 best practice guidelines, and we have 4 implementation tools. We have an implementation tool for service organizations, and I will speak briefly about that. That is a tool that we brought the 3rd edition this past February. And we also have a tool for integration of the best practice guidelines into curriculum, as well as a specific focus of another tool on primary care, because we believe primary care is central to effective healthcare systems. And then we also have one specific to mental health and substance use because of the challenges that are experienced in society today. As I said to you, the program has been funded by the government of Ontario since 1999, with the goal to develop, disseminate, and actively support the uptake and sustainability of clinical and healthy work environments and system best practice guidelines. We, in fact, are now developing the 2nd edition of care transitions from one part of the system to another. And to evaluate the impact, it's critical, of organizational health system outcomes. That's absolutely critical. In terms of implementation, where I want to focus now, we have many aspects to implementation, and you can see them around that circle, from micro to meso to macro. Those are the 3 levels of the circle. The most impactful one is, no doubt, is the best practice spotlight organizations. And I told you that I will speak a bit about the toolkit that we use with BPSOs. So, and the 3rd edition that we just issued this past February. We always use the knowledge to action framework. What we did this time is what we were using from the heart in terms of social movement action. We developed a social movement action framework. And that framework is no different than the big social movements that you can think of, right? Could be Black Lives Matter, could be the Me Too movement, any movement that you can think about. When you think social movement, just think about those elements. What we did here is to do a concept analysis of social movement in the area of evidence uptake and sustainability. So when you see here the preconditions, characteristics, and outcomes of social movement action, this is specifically related to evidence uptake and sustainability. And you see many of the elements that I already spoke about, the need for urgency, the collective identity, the visibility, right? This PIN is not only collective identity, it's visibility. The fact that we publish a lot, the fact that we do a lot of social media, that is visibility. That is typical of social movements, and the need, the urge to change the world for better. In our case, the urge to change the lives of students, to think about practice, evidence-based practice, of faculty, that no one would even ever think that you don't do that evidence-based, and also evaluate outcomes. So to teach all those aspects linked to policy, because lives happen in the socio-political context. And the same goes for practice, that nurses not only practice based on evidence, that they also feel that they're change agents, that it's in their hands to improve the lives of patients, their families, and of their colleagues. It is also in their hands to provide input to work environments. And here are the elements. We are now in a tremendous process with the team This part is under the leadership of Susan McNeil of developing competencies for the social movement action framework, and competencies that we will teach, and you will be able to take all of this because it's free of charge in the website to teach students and to teach other colleagues. I forgot to mention in the guideline development arena, the person in charge is Nafsin, who is doing with a tremendous group work on the development of guidelines. Let me move to what is BPSOs, which would be, you can equate it to, this is the robust quality improvement initiative that I was asked to use as a case example. You already saw a bit of the three buckets, and now I am giving you a little bit of each one of them. This one is the key element of the implementation strategy that we use, the best practice spotlight organization. The goal of these organizations is simply to influence the uptake and sustainability of best practice guidelines across healthcare organizations in all sectors to enable practice excellence and positive client, organizational, and health system outcomes. And we do that in various ways. There are different models of BPSOs. I will stop for a minute because I see my grandson, Morcito. Can you open the door to Noah? Sorry about that, but that's important too. That's energy, energy, energy. So there are different models of BPSO. We started with BPSO Directs. BPSO Directs are organizations that initially reported only to us. BPSO Directs now report to host organizations. Here in Canada, it's us. But for example, in Spain, it's at the level of the federal government of Spain. In Chile, it's the national government of Chile, and so forth. And they become BPSO host, national, regional, and specialty, and they implement within their country. The last one is BPSO OHT, which is like your HMOs. Here they are called Ontario Health Teams. You have HMOs for many, many years, integrated systems of care, and we work with them across all sectors. We train them across all sectors, and we train health professionals from across all sectors. So just picture, right? A few weeks ago, the team trained about 240 people from one Ontario Health team. And some of them, frontline people, were for the first time meeting with one another, knowing of the other sector. So imagine the robust staff engagement that this social movement action brings, alongside the knowledge to action, which is much more systematic and much more directive on how to do. So one is more, here is how we go about gap analysis, here is how we go about meeting with stakeholders, et cetera, and analyzing. The other is much more like life itself, more fluid, more dynamic, but the two together accelerate evidence uptake and evidence sustainability. Going back to the four types, so we have the models and we have the types of EPSOs. One type is service organizations, the other type is academic organizations, and we also have indigenous focused BPSOs, and you will be able to see some of that. Globally, we have well over 1,000 organizations in 20 countries around the world, implementing through a formal agreement with RNO. And Raul, you can put my email and your email, please, and Michelle's email if you have. And we actually sign formal agreements. As I said, we don't charge money at all, but we do charge commitment, a tremendous level of commitment. We meet with you, we train you after you sign. We provide you all the materials from guidelines to the PowerPoints, et cetera, and then you can also use Inquire. You will hear it in a little bit to measure your outcomes. And you become part of this amazing collective that is changing the world through quality improvement. One more important piece that I want to mention, and you can think about that as a quintuple aim if you want to think. You may want to, you probably all know the quadruple aim, right? The quadruple aim of improved patient experience, improve patient outcomes, improve health provider experience, because we know that if health providers are satisfied, if nurses are happy, patients are happy. You can think it that way, and that goes for any other discipline. And also, all of that together produces lower cost. What's missing in the quadruple aim is the SDGs, the social, right? The development, the sustainable development goals, basically the social and environmental determinants of health, which are which are the sustainable development goals. And that's why we say quintuple aim, question mark, right? Because it's very different to use evidence to improve the outcomes of a person that lives in a mansion versus improving outcomes using evidence in the person that lives in the streets of our communities or in a shelter or in an underserved population. It's very different, and that's why you cannot optimize health for all only with the quadruple aim. And this is why at RNO, both for policy and practice, for all of our programs, we actually integrated the sustainable development goals. Champions. What are champions? We have over 100,000 around the world. Let me be clear, these are not people that all they do is to teach the program or to help with the program or to implement this quality improvement initiative in their workplace. These are people that most of them are frontline nurses. In some countries, like in Chile, they have dedicated from the government some champions that all they do is this work for the government of Chile with outstanding results. But the 100,000 of them around the world, most of them work full time with a little bit of a decrease. When you thought in the past in the US, I lived in the US for 6 years, about clinical nurse 1, 2, 3. Remember, clinical nurse 3 received 1 day a week. That was to develop projects. This will be what you would do with the champions. And the champions are in all the countries and do give legs to the program in their own country, trained by us and reporting supported by us. We have champions. The previous one was Latin America and Spain. This is in China. We did that whether it was in person or also we did a lot. These 2.5 years, we didn't miss nothing. We absolutely, we miss free time, I would say, but we train people all over the world. We added many people. I was just yesterday working with our team in finalizing our annual report because our annual meeting is early next week. That's why I couldn't be in person at your place. But we added new VPSOs hosts. Countries added many VPSO directs to them. The work continue intact, using Zoom and using rooms within Zoom. Now let's talk as a last a few remarks about the importance of evaluation. You cannot implement a robust quality improvement program without having evaluation. It is simply irresponsible. So it is critical to have evaluation in any quality improvement program, and our quality improvement program has a tremendous evaluation program, a whole program of evaluation for monitoring and evaluation, because what we do is we use the results to inform all the organizations. They draw their own reports. So you have within evaluation inquiry. And that's what I want to talk a little bit about because it is absolutely critical. We need to evaluate the impact of evidence-based clinical and healthy work environment guidelines on patients or clients or residents, depending which sector and how we call people, right? Because they're people, in organizations. And you need to also be able to evaluate the entire results of the program. So in the case of Chile, in the health system, they need to evaluate, and they are. In the case of an organization, if you are looking at the quality improvement that you are implementing, you need to evaluate not only within the specific unit, but the entire organization. And we do that on an ongoing basis. We have two systems for evaluation, and we are actually now in the process of bringing them into one. So, and remember I was telling you, one of the principles at the beginning is leading edge. Well, leading edge is to know what you need to continue to shape. And in this case, we are bringing together those two systems into one. And that will be leading edge because it will allow us also to use artificial intelligence to predict results in a beautiful way, to produce new knowledge in a beautiful way. So in a future conference, we could come with our team that is doing the work on artificial intelligence under the leadership of Dr. Shanoya Naik, and we will be delighted to present to you. Heather McConnell, that directs the operations of the program, myself, that directs the vision and direction, and of course, NAFCIN, guideline development, Susan, implementation, and Dr. Shanoya Naik on evaluation. We will be delighted to do with you a living panel, a living workshop perhaps, where we can work on all of these aspects. So one system is Enquire Data System for quantitative data. At this point, the organizations put the quantitative data at the unit level, and we teach them how to do that. We have manuals how to do that. All of this, by the way, is on the website. You are welcome to look at that, and if you want to learn more, we will be put in touch with the right person to guide you. And if you want to join the program, please send a note to me. And then we have the MyBPSO qualitative data that comes from audits, that comes from reports and narratives. And when you put both together, you get the quantitative and you get the qualitative of words where artificial intelligence start to pull themes that come out of all that massive amount of data that is over 1,000 entire organizations, right? You cannot do artificial intelligence without having mega data, and this is where that comes to play so nice. So Enquire is comprised of a data system of PPG-specific indicators, of course, using Donabedian, so structure, process, and outcomes, and the online reporting, which I spoke with you, that interfaces. And Enquire collects data from BPSOs, from these 1,000 best practice spotlight organizations. It's mandatory that they report, and they produce basically reports that the organizations can pull in a variety of ways, can even compare one another, and can put bar charts, etc. You will see some of them use. The beautiful piece is that people use these reports to go back to staff nurses that are the ones putting the practice in place, or students or faculty, and actually tell them how things are going with data in front of their eyes. The beautiful piece of Enquire is that you can also do annotations. So if something goes different than what you thought, you can see why. It's not a closed box that you don't know how did it happen, but actually it helps for them to know. We produce evidence boosters, and we have a manual, again, it's on the website, for evidence boosters that are used through Enquire. So people basically, you will see these are evidence boosters. People they get a mind booster with the specific guideline. The booster already comes with what is the guideline, a description of the guideline, but then colleagues can pull their own data from Enquire, put it on the booster, put the practice change that they did, and they can use it. They can use it for quality improvement with their board. They can use it for quality improvement with the patient safety committee. They can use it for a conference. They can use it for a publication. It's their data, it's their evidence boosters, it's their results. And of course, the only thing we do demand is that they use the evidence boosters also to meet with staff to tell them how they're doing. All the guidelines have produced results, all of them, all of them. There is not one single guideline that does not produce positive results. And the beauty is that those results have been produced 6 months after implementing the guideline. You know, usually people say that the quality improvement takes anywhere between 3 to 6 years or more to take hold. Not the case with the best practice guidelines program. Within 6 months, people start to see results, and then those continue forever and ever because we have a full sustainability program. I want to share with you the experience of indigenous BPSOs. It's a whole program dedicated to wise knowledge combined with the traditional ways of knowing of our guidelines. It's a program that is guided and directed by indigenous people. It's a program that has both a guideline that we are actually now issuing on a decrease in smoking on women during the gestational period and beyond. And is also a program that has now 9 best practice spotlight organizations in indigenous communities, and the first ever best practice Ontario Health Team BPSO with indigenous focus, so people from all across all sectors in that specific health team. So I want to acknowledge my colleague Raul Pinto, who produced this amazing video with our indigenous colleagues and the BPSO's Indigenous Focus and the team of Grace Suba, Rachel, and Tanya that work with that team day in and day out, and the leaders of those BPSOs that work many times in difficult circumstances and are making knowledge, both wise knowledge and traditional knowledge, come to life for indigenous peoples to actually do the best care possible with the best outcomes for everyone. So miigwech, chimiigwech, and thank you very much, and absolutely a pleasure to be with you. And if there are any questions, we can spend a couple of minutes if you still have the patience for it. But thank you very, very much.